Welcome to myeyacademy.com. I'm Professor Mahfouz Hussain from Pakistan. It's a unique platform on website and YouTube channel for ophthalmic teaching. In this video, VHB Video Handbook Chapter 10 Section 4, we will discuss close angle or angle closure glaucomas. Look at the diagrams here. Both these eyes have got open angles, so if they develop the glaucoma, that we will call open angle glaucoma. Now look at the eye here. Look at this eye. The iris, if it moves forward like this, now the angle is narrow. So if this eye develops glaucoma, it's going to call angle closure glaucoma or closed angle glaucoma. So open angle glaucoma and closed angle glaucoma. And now we'll classify them. Open angle glaucoma is classified into primary and secondary open angle glaucoma, and the same way angle closure glaucoma is classified as primary angle closure glaucoma when the angle closes without any cause, and secondary angle closure glaucoma when there is a pathology which causes the angle to close, and we'll discuss that later on in the lecture. Now concentrate on this slide. We're going to discuss the mechanism of developing angle closure glaucoma. I would like you to concentrate at this area. In this area, the iris and the back of the cornea makes an angle, and that's called angle of the anterior chamber. So look at this anterior chamber angle. It is open. If because of the aging or some other cause the lens swells up and moves forward, look at that. Now once it moves forward, that blocks the pupil and the iris bows forward and closes the angle. So now this is a close angle or angle closure. Angle closure glaucoma will develop because of the pupil block, so we need to give an alternative route for the aqueous to flow from the posterior to anterior chamber. So we are going to make a hole in the iris like here, and because of this hole the aqueous can flow from the posterior to the anterior chamber, and that will relieve the angle closure. This hole in the iris is called iridotomy, and we do it with the YAG laser, so it's called YAG laser iridotomy. In reality it looks like this. There was an angle closure, we made a hole in the periphery of the iris and provided or gave a way to the aqueous to come from posterior into the anterior chamber, and so we relieve the angle closure glaucoma. Now the angle closure glaucoma can be primary or secondary. The cause for the primary or secondary angle closure glaucoma, if the angle closure glaucoma is primary, it's usually in the small eyes. So in the small eyes the anterior chamber is crowded and there's a forward movement of the lens with the age, and that causes the angle closure glaucoma. While the cause in the secondary angle closure glaucoma is the blood vessels may develop in the anterior chamber and actually pull the iris anteriorly to close the angle, or there may be an inflammatory membrane that contracts and pulls the iris forward and closes the angle. So the mechanism in the primary angle glaucoma is pupillary block and angle closure glaucoma, while in the secondary angle closure glaucoma the angle is closed either because of the inflammatory tissue or the blood vessels which actually pull the iris forward and close the angle. Treatment for the primary angle closure glaucoma is myotics. The myotics constrict the pupil and create a distance between the lens and the iris so the aqueous can flow into the anterior chamber. If the medical treatment doesn't work, we can do the peripheral iridotomy as we discussed. If that doesn't work, we can do the trabeculectomy, which we'll discuss later on. Secondary angle closure glaucoma, you have to treat the cause. If the cause is inflammatory membrane, you treat the inflammation. If the cause is new vessels, you treat the new vessels, and that's you reduce the chances of developing further angle closure glaucoma. Laser may or may not work, and the trabeculectomy is the last resort. So now the treatment of the angle closure glaucoma. We have already discussed that the angle is closed either because of the pupillary block or because of the pulling of the peripheral iris without pupillary block. Now the treatment is medical treatment to reopen the closed angle, or the medical treatment to increase the outflow or decrease the production, as we did in the open angle glaucomas. The parasympathomimetic drugs are used to reopen the angle in the pupillary block glaucoma, and the mechanism is slightly different as it was in open angle glaucoma. Here, the pilocarpine constricts the pupil, creates a distance between the iris and lens so the aqueous can flow into the anterior chamber. The other things are beta blockers. They decrease the production by their beta adrenergic blocking action. Then the prostaglandin analogs, and they increase the uveoscleral outflow, and carbonic anhydrase inhibitors like acetazolamide, they reduce the aqueous production. So the medical treatment is either to reopen the pupillary block or increase the outflow or decrease the production. If the medical treatment doesn't work, then we have to switch to the laser and the surgical treatment. When the medical treatment fails or is not sufficient, we switch on to laser treatment or the surgery. Laser treatment is done with the YAG laser, and YAG laser is used to make a peripheral iridotomy, as we've already discussed. This makes a hole in the iris and the aqueous flows from the posterior into the anterior chamber. If that doesn't work, we have to switch to the surgical treatment, and we do trabeculectomy, which is an alternative route for the aqueous to drain into the subconjunctival space and gets evaporated. This is the photograph of the YAG laser iridotomy, and in the next slide we'll discuss the steps of the trabeculectomy. These are the 6 steps. Peritomy, which is the conjunctiva is separated from the subconjunctival space, and then the partial thickness scleral flap, then the deep sclera is excised. Peripheral iridotomy is made, as here sclera is sutured and conjunctiva is sutured. All these steps can be seen in the video VHB 18.7. Angle closure glaucoma can be primary or secondary. First we'll discuss the primary angle closure glaucoma, and after that we'll discuss the secondary angle closure glaucomas. First we'll discuss the primary angle closure glaucoma. To diagnose a patient with the primary angle closure glaucoma, you need to have the basic things like high intraocular pressure, disc cupping, and nerve fiber damage, which is detected with the visual fields and OCT. Then the patient needs to have a close angle and no known cause for the close angle. That's why you label it as a primary, because there is no known cause. Incidence is usually in the 5th decade onwards, because after the 5th decade the lens is swollen enough to cause the pupillary block. Females are 4 times more affected than the males, and it's a usually bilateral condition. Risk factor is hypermetropia, because in the hypermetropia the eye is small, so that predisposes you towards the angle closure. Mechanism is a small eye lens blocking the pupil and causing the iris, periphery of the iris, to bow forward and close the angle. Treatment is medical, laser iridotomy, and trabeculectomy. Now the stages of the angle closure glaucoma. Angle closure glaucoma can be described in 4 stages. That is primary angle closure glaucoma suspect, intermittent primary angle closure glaucoma, acute angle closure glaucoma, and chronic angle closure glaucoma. What's the difference between these 4? In the primary angle closure glaucoma suspect, the patient do not have any symptoms, and doctor checks the eye and thinks that the patient is likely to develop angle closure glaucoma, so we do the YAG laser iridotomy to prevent any future attack or prevent future development of angle closure glaucoma. Now remember, these patients don't have any symptoms, and we just think that the patient can develop angle closure glaucoma in the future. In the second stage, intermittent primary angle closure glaucoma, there's intermittent blurry vision and halos in the vision because the angle gets closed and reopened, so the patient get intermittent symptoms. So we again do the prophylactic peripheral laser iridotomy to relieve the symptoms. In the acute attack, the angle suddenly gets closed and there's a severe pain, halos, red eye and decreased vision. We will discuss the angle closure glaucoma in detail in next slide. The fourth category is chronic angle closure glaucoma, where the angle closes gradually and permanently. I repeat, gradually and permanently, so the drainage cannot be done, and this is like chronic simple glaucoma or open angle glaucoma, so you gradually angle closes and cannot be drained. Symptoms are loss of vision and intermittent pain, and treatment is either medical or trabeculectomy. Laser usually doesn't work in this case, laser iridotomy I mean, because even if the aqueous comes into the anterior chamber, it cannot be drained because the angle is zipped off. So this is chronic primary angle closure glaucoma. Now in the next slide, we will discuss acute primary angle closure glaucoma. Acute primary angle closure glaucoma or acute attack of primary angle closure glaucoma. Physiological pupil dilatation causes pupillary block, which results in bowing of the peripheral iris, and hence the angle is closed. Symptoms are acute severe pain. Pain is so severe the patient can vomit, there's a redness of the eye and loss of the vision. Signs are high intraocular pressure, corneal edema because of the increased pressure, redness, shallow anterior chamber, and because of the ischemia, fixed mid-dilated pupil. Now the treatment can be divided into three parts: the treatment of the acute attack to relieve the pain, then the treatment to prevent future attacks, and the treatment of the fellow eye so that the fellow eye doesn't develop angle closure glaucoma. Acute attack is treated with systemic acetazolamide or mannitol intravenously, which constricts the vitreous and relieves the pupillary block, pilocarpine to constrict the pupil and relieve the pupillary block, and you can also use the other medical treatment to reduce pressure, and peripheral iridotomy to make an alternative route for aqueous to come into the anterior chamber. To prevent the future attacks, you need to do either the peripheral iridotomy or trabeculectomy depending on your decision and expertise. The treatment of the fellow eyes, you initially give the pilocarpine eye drops to constrict the pupil so the other eye doesn't develop pupillary block in the near future, and then you do the peripheral iridotomy to permanently relieve the blockage of the pupil, and so the development of the angle closure is stopped. Just a quick reminder, angle closure glaucoma can be primary and secondary. Primary angle closure glaucoma we've discussed in 3 steps: primary angle closure glaucoma itself, stages of primary angle glaucoma, and acute primary angle closure glaucoma. Now the secondary angle closure glaucoma can be because of 2 different mechanisms. In the one, the lens comes forward and blocks the pupil, and hence the angle closure glaucoma because of the bowing of peripheral iris like this. The second mechanism is pulling of the iris because of the contraction of a membrane in the angle, and that membrane can pull the iris towards the cornea and can close the angle, causing angle closure glaucoma. So secondary angle closure glaucoma can be with pupil block and can be without pupil block because of the pulling of the peripheral iris. First we will discuss secondary angle closure glaucoma with pupil block. The mechanism is increased pressure in the posterior chamber pushes the peripheral iris forward and blocks the angle. It can happen in the following conditions: when there 360-degree blockage, like the pupil gets stuck to the lens, which is called synecdoche. So when there 360-degree synecdoche, the aqueous cannot flow into the anterior chamber and pupil is blocked, so the angle closure can develop. A subluxated lens can block the pupil physically, and so the angle closure develops. Or the mature cataract can swell up to block the pupil, or an anterior chamber implant can block the pupil. So in all these four conditions, the pupil is blocked, which causes bowing of the peripheral iris anteriorly and blocks the angle. So these conditions cause secondary angle closure glaucoma with pupillary block. And now the last one, secondary angle closure glaucoma without pupillary block. Here the pupil is not blocked, but the peripheral iris is pulled forward to close the angle. The peripheral iris can be pulled forward because of the fibrovascular membrane or peripheral anterior synecdoche, and that closes the angle physically, though there is no pupillary block. So the secondary angle closure glaucoma is either with the pupillary block or without the pupillary block. Thank you very much for being with me, and please do give your feedback. Thank you.